Hi guys, welcome to the first episode of the Sliding Scale podcast. Uh,
Hello, everybody.
I'm Narendran, and this is
I'm Anirudh.
So we're here today because we wanted to tell you a story. Well, Anirudh wanted to tell you a story, and hopefully we can all take something away from it. So go for it.
Okay, so I thought you were going to give me a better intro, right? So we decided to talk about one of what I decided to talk about one of the best memories that stood out for me as a surgical resident, which happened a couple of years back. Actually, two things stood out to me, and I thought, the former story seems like a more reasonable one to talk about because, well, I mean, both stories have a happy ending, but this one just shows me in a better light, I feel. So, being a little bit selfish there. Um, so, do you want to, Narendran, do you want to tell people what we're going to talk about today? Or,
Yeah, I think something that we as residents or just healthcare workers in general tend to not do is talk about work with the general public, or even talk about work in a meaningful way amongst ourselves, even with our peers. It's usually just limited to whining about work or how difficult it is or how taxing it is on your mental and physical health, which it is, but I think a lot of times it helps to just take a step back and see if there were any teaching points or learnable moments during your day which may not have seemed very obvious to you at that particular time because you were stressed or you were overworked or you were sleep deprived, and that may not really have been something that you really picked up on in that given instance. And I think I've had so many such moments during my, and either a peer of mine has pointed something out which would have never struck me, or my senior would have pointed something out, or I may have done something very reflexively, but and the gravity of that decision might not have really struck me at that point of time. But looking back now, I will always think, oh wow, such, not it may not be profound, but it will definitely be something important, something that might be life changing for your patients. And I think the whole premise of having this podcast is that we come from diametrically opposite but synergistic fields which end up teaching us so much about each other's fields. And I feel like if you're able to learn from, being a physician, if you're able to learn from a surgeon's successes or mistakes and vice versa, it's just going to make you a better whatever you are. So hopefully, and Anirudh and I have learned from each other since we were in MBBS, and hopefully we'll be able to spill some of that onto you in this. That's the goal. So fingers crossed.
yeah, fingers crossed indeed. I'd like to, point out that we're not going to be talking only about our success stories. We're definitely going to be talking about failures because I think there's a lot to learn from the failures of other people because you can dissect it much easier and it's much more palatable to look at somebody else failing and not just judge them for the fact that they fail, but learn something out of it because wisdom is when you learn from the mistakes of others. So, enough of introductions. Let's just jump right into the
Yeah,
story. Right. So, I think I've told you this if I
I'm sure
recall.
you have.
I mean, despite the great friend that you were during your residency.
But podcast is not for us to talk about you and me, it's for the people. So
Yeah.
tell them this story.
Yeah. It's for the people. Right. But I had to bring it up. I just had to. Right. Yeah, so this was in my final year of my residency. I did my MS General Surgery in a government institute in Kolkata, far away from home. Feel like all the odds were against me, and I reached there. 3 years, 2.5 years were done, and I was at the last leg of my residency, and I was just a few months away from my exams. It was at a point in my residency when our chief was confident about our own surgical abilities where we were just starting to operate, right? We were getting chances to operate on big cases. And I mean, I'm sure people who scrubbed for cases will tell you washing for cases is probably one of the most euphoric things that you end up doing during your residency, even if it's a very minuscule, probably insignificant part of the surgery itself. So this was one midweek. It was a Wednesday, I remember, because it was post OT rounds. We have operation theater days on Tuesdays and Thursdays, and admission days on Saturdays. So it was a Wednesday, and just my chief, myself, and one of my juniors were giving rounds, and we had about 35, 40 patients, how government hospitals be. We were just done with almost half of our rounds, right? And so we were finishing up in the female ward, and there was one patient who was scheduled for a right hemicolectomy because she had a hepatic flexure growth. And we didn't really have a functional surgical oncology or a surgical gastroenterology department, so everything started and ended with the general surgery department, and that way I was very fortunate. So she was an elective case, and she was getting planned for this surgery, and she was doing well. We admitted her on Saturday, and she was doing well so far. We were just getting all the checklist done for her anesthetic checkup, optimizing her bowel prep and nutrition, go on, so on, so forth. And we were just casually reporting, saying, sir, the patient is so and so, so and so, and we're planning her for a right hemicolectomy. And nobody paid any attention to it. But the thing about surgical patients is, right, they're almost always awake, because they're either waiting for the surgery and they're anxious, or they're in a little bit of pain post-operatively, or we don't let them lie down, right? So we just like to keep them mobile all the time. So
Sadistic people.
it's for the good of the patient. Trust me. We'll talk about these things as well. But she was lying down on the bed, right? And she seemed to be not normal. Something seemed off, and it just struck me in passing, right? We finished the patient and we were walking out of the wards, and it appeared that she was in some form of distress, right? Immediately something just went off in my head. Alarm bells go off in my head. I didn't know what was wrong by then, right? I was still thinking, okay, something is wrong, and that patient needs more attention than she already has gotten, right? So I figured I'll just step back a little bit and have a closer look at the patient. And I turn her over. I ask her relative, I think her mom was with her. She was a middle-aged lady, by the way, late 30s, I suppose. Her mom is like, no, she's been okay. She went to the loo in the morning, and she came back. She said she's having a bit of abdominal pain, and she just laid down. She hasn't had any food in the morning. And that was a bit odd. And I asked the patient herself. She was not in a lot of space to be able to actually talk about her problem. She was distressed. She had that typical frown on her forehead. We see on the visual analog scale, say about 6 or 7, you'll have that smiley face with a frown on their forehead. And immediately on instinct, my hands go to her heart rate, radial artery pulse, and she's having tachycardia, which means, for the non-medical people who hopefully will listen to our podcast, that her heart rate's normal, higher than normal, sorry. So, and that just means that something's going wrong in the patient, right? It may be that they already have that kind of a heart rate, but almost always you just kind of know that something's going wrong. So the next thing I do is put my hand on the patient, and it's something, as a surgeon, subconsciously you're trained to identify. It was a surgical abdomen, right? She had a distended abdomen. It was hard as a wooden board, like a table. And she did not allow me to actually get access into palpating or feeling for her internal organs. So at that point, I still don't know how I said the next few words that I did. I just called everybody back. I mean, there was two other people. I called everybody back and I said, something's wrong. I think the patient has a perforation, right? And my chief, right? He's like, he's one of the best educators I know, and he generally never disagrees to anything outright. He tends to try to make you understand why you were wrong and make a lesson out of it. But at that instance, he said, no, 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 how can a hepatic flexure growth perforate, right? And I said, I didn't know, I had no answer to that, right? At that point I said, okay, I don't know, you probably know something more than I do, but I just know that something's wrong in this patient. So The way it works in our department or in our unit, worked rather, it's been a while since I was working there. So worked in our unit was, we had packed elective OT days, right? We start at 9:30, 10 in the morning, and it went on till it went on. And this patient who was chalked for the surgery that week was kind of a surplus, so she may or may not have been posted that week. Might have to have operated on her the next week. This is generally how it goes. So given that scenario, we needed to get the patient operated somehow, and the fact that this patient was, supposedly having an acute abdomen that warranted an urgent exploration, my chief said, just get an x-ray, see if there's any problem. If there is even a shard of doubt that you think the patient might have a perforation, just take the patient up tonight, explore, and see what happens. So the fact that, your unit chief is giving you that authority to take a call just when you're in your residency was very empowering, right? That was probably one of the first times I actually felt like, okay, so this is how cool it feels to be a surgeon. So I said, get the x-ray done. An erect x-ray means, you make the patient stand and you take an x-ray. Presumably, if a bowel or any part of the intestine gets ruptured, the air inside, all of our bowel intestines have air, and this air leaks outside. So you'll see that in places where air generally is not supposed to be there. So, and air tends to float. So if the patient's standing up, it'll be in the upper part of the abdomen, just under their lungs. So we got an X-ray, and I failed to remember if she actually had air under the lungs, to be honest, but I'm sure there was some finding that made me think she needs an exploration. Plus, she wasn't getting any better, right? That was more of an indication to me that something's going wrong than the X-ray itself. Sometimes you may not actually find findings. And I told the boss about this. My sir said, it's okay. It's on the edge. It could be yes, it could be no. Anyway, we need to explore this patient for a surgery. Might as well take her up tonight, after the admission day units tables are free, and see what happens. So we informed the duty senior resident on call. It was a very nice person. He said, we have a couple of cases only, and considering that you might have a perforated viscous, which means, so basically all the stool gets into the abdomen, and presumably it's a bad thing,
Yeah.
right? So so this is what produces the inflammation or the rigidity and all the increased heart rate, and why the patient was looking so sick. So we reserved typed and matched blood for her. We resuscitated, we gave her fluids, we made sure the urine output was good, we made sure that the physiology was as good as we could get it, and we took her up for surgery at around 11:30 that night. And the moment we opened the abdomen, right, it smelled so bad. It's one of those things, right? It smells so bad that the smell sticks to your nose and you keep remembering it for the next couple of days. It was that bad of a smell. So we knew that she'd perforated just based of the fact that there was a stool smell coming out through her abdomen. And we explored the abdomen. We found that the mass was there. And then just before the mass, the cecum, right? That's the starting part of your large bowel. That had perforated, and in a very unusual place as well. It was in a non-exposed part of the abdomen, right? So it was that, which kind of explains why her X-ray was not very confirmative for her having a perforation. But I was very euphoric. I was like, yes, I got it right. And we resected, we did the anastomosis on table right then and there. And as we were closing the abdomen, my chief calls me. It was about 1:15 in the morning, because we had to give a lot of wash. It's one of those things that you need to do. And as we were closing the abdomen, my chief calls me, and calls one of us, and he asks what the finding is. And my junior, he says, sir, there was a perforation in the cecum, and we had significant soiling of the peritoneum. We had to resect and wash and do a primary anastomosis, and we're closing the abdomen up. And my junior told me that my sir said, oh, Anirudh got it right. And that was the biggest achievement I'd had in a really, really long time, right? So, the patient went home. But the reason why I picked this story is There are times in our residency, right? I'm sure you can agree with this, where we feel like we just end up doing a lot of mindless work. There's paperwork all the time. You end up preparing patients for somebody else to operate and somebody else to take credit for, somebody else to have that euphoric high when you end up in the wards having to manage all these complications, which most of the times don't really affect people above the first year, second year residents,
Yeah.
right? They tend to be immune to all these things. It's not their fault. It's not like we're blaming them. It's just how it works, right? So the fact that all of my years of supposed mindless toiling created this subconscious pattern recognition, right? That is what I feel saved that patient. I'm sure if we had missed that finding that morning, we would have seen the patient only the next day, maybe even later. I can't even tell you when we might have seen that patient. And by that time, it might have been too late, right? She's a mother of kids. She's the wife of somebody. She's a beloved person of some family. She might be a case diagnosis or a bed number or a, I don't know, nameless person with flesh and body and nothing more than that. But they are actually a part of somebody else's life. And the fact that I was able to catch this on time before anything really bad had happened and the patient walked home, I feel like everything that I felt was mindless about my training paid off at that point, right? So that's the point I want to push across. Don't think that you're doing something mindless or don't do something just for the sake of doing something. Everything that you do is going to help you at some point in time as long as you're taking willing to take something out of it.
Yeah, I think that the the biggest thing, I mean, the biggest takeaway for me from that was that you have this ability to pick up on little nuances as you get better. And the only way that you'll be able to pick up on those nuances is if you have done the groundwork and if you have done the scut work and if you have.
That is really important. People diss on scut
Yep,
work so much, they don't realize how important it is. It's not just the fact that you're doing things that you don't want to do. It's those things that teach you the small things. The devil is always in the
exactly.
details,
And I
right?
think I think that's what really gets to people, especially when you have students coming into residency from like private medical colleges where they were not expected to do anything in internship, and they were just like, oh, like, residency is also going to be something that I can just walk through. They always have this mentality that, okay, like in first year I'm just going to do the bare minimum and get past, and when I come to second year I'll be able to see all these fancy things and make all these fancy diagnoses and be able to treat all these things with fancy medications or do fancy surgeries in your case. But the the whole premise behind us giving procedures and us giving like more advanced thing to our seniors is because they have been through a lot more than you have, and that by in and of itself gives them the ability to pick up on things that are not there. It's very easy to see the things that are right there in front of you. It's very difficult to develop the maturity to be able to pick and spot the things that are not there. And I think in your case is very illustrative of the fact that you were able to pick up something that was abnormal about the patient because you knew what to look for in a normal patient who had just a colonic growth. You figured that she shouldn't be like this. She shouldn't be in pain or in.
Right. It's not that you're going to find these things in all
Exactly.
your patients. It's the fact that you look at normal patients so many times. Normal patients, in the sense, whom you expect to have a physiological or a near normal outcomes generally. It's those patients that you keep seeing over and over again that helps you pick up these subtle signs that makes you want to take a second look. It's not that me walking past that patient uh, with the patient lying down made me, okay, get a spidey sense like, oh, something's off. I know that she has a perforation. No, it's the fact that it made me want to take a second look, right? I think that is what all the scut work, all the sleepless nights, all the triaging patients in the ER, all the preparing patients for surgeries, all the complications that we had to manage, That is all what it boiled down to, right? That one instant moment that you where you felt like you were house MD, except that he had a written show and he was not a doctor.
Yeah, no, I get it, and I think the flip side of it is that being able to stand up and say that, oh, I found this thing which goes against everything that all of your seniors and your chief has said.
Right, right. Yeah. I never
And
actually
having
thought
the
about
balls to
that.
say that, you know what, I think you're wrong, and this might be completely wrong, and I might be a complete idiot, but I think it's
I'm
I think
willing
it's
to
a
take that
value to at least
chance.
put this information out there, and then do what you will with it. That's up to you. I think that takes a lot of courage, and I feel like I think you and I were fortunate in that we had chiefs that were at least a little open-minded when it comes to patient care, and they
Yeah,
they weren't outright like, oh, like I'm the chief and you're just a resident. You shouldn't be even opening your mouth during
right.
rounds. Or
I think the fact that I was able to stand up and say that, I feel like this is
yeah,
the problem is stems from the fact that we had chiefs
exactly.
who listened,
And I think that's
right? I think it goes both
definitely
ways.
very
Yeah.
important. I think having the leeway or the freedom to treat patients the way you want, within a reasonable amount of, like a reasonable window of error, is something that is so important for residency. And I think people get caught up in things like, oh, should I go to a private college, or should I go to like a government college, or should I do DNB, or should I think the thing that you should be looking at is who you're going to be working with, like what kind of people are there. And I know that that's a very difficult thing to judge
It's a roll of the dice. It's
the
definitely a
dice. And
roll of the dice. But when this is something we talk about to our juniors and people who ask us for help, over social media or even people in our respective institutes, right? Is how to pick an institute. The reality is you don't pick an institute for its name or fame. You do the groundwork. You make sure that you network and you find
absolutely.
out what you can expect from a specific institute, right? And that makes a lot of
Absolutely. I think
difference.
it's so important to like go to an institute and see what the place is like, what kind of features it offers, both in terms of exposure and in terms of like what kind of people you're going to meet there. All of those things make a huge difference. And I think there are amazing private institutes which will give you a lot of exposure and a lot of sound education. And there are really crappy government institutes where all you will do is mindless cut work and come out like just a glorified MBB.
Barely
Yeah,
any skills or
exactly.
knowledge,
So
right?
yeah, I think that is important. The fact that you had the balls to stand up and say, and the fact that you were fortunate enough to be in an environment where you could have the balls to stand up.
Exactly. I think that was, it's
I
both
think
sides of
yeah, I
that,
think
right?
uh, I think both of those things were important for that to happen. But yeah, I think that's it's definitely an experience that everybody should have. Um, you know, being right when everybody else is disagreeing with you, a
Stands
different
against
kind
you,
of right.
yeah.
Uh, but yeah, I think
Yeah.
these are the things that need to happen before you have that kind of a moment. One is you need to do the groundwork,
Right.
and you need to prepare yourself to be in that situation. Honestly,
Right. You can't end up being lucky on that day, right? It's like luck is
yeah,
hard work in action. Years of hard
if
work
you have
compounded
just
into
been,
action, right?
callous about your first 2.5 years of residency and just gone through the motions instead of being, what's the word, deliberate about, the work you did, I think you
Yes.
might have just missed it. And like you said, you might have even lost the patient. Perforations are not
Not a
they're
joke,
not fun
not
things. So
a
you
joke.
might have actually lost that patient if you hadn't stepped up that day. So
I think that's a nice title for our episode, right? The importance of
yeah, I
being
think I
deliberate.
think so. I also think it's a good place to stop because we've
Yeah,
been
I think
rambling
so
for
too.
25 minutes and I don't think they're going to listen.
Yeah, we have.
But yeah, so thank you guys for the people that stuck around till here. But
If you guys want to listen to more of these things,
yeah,
please
or
let
if you
us
have any
know.
questions, comments, concerns about residency or internship or medicine or surgery or any of the allied branches, please feel free to let us know, and we will do our best to answer them. Or maybe we'll have somebody come onto the podcast and answer them.
We can do that too. So share this with somebody you think who would find this interesting, and please follow us for more such interesting episodes. See you all.